Great. So today's session, titled How Managed Care Helps Transform Foster Care Systems, is brought to us by Sellers Dorsey. Sellers Dorsey has been a longtime gold partner and supporter of both MHPA and our health plan members. I want to thank the entire Sellers Dorsey team for pulling together today's session and sharing their expertise with us. With that, I will toss things over to Katie Olse, the Senior Director for Child and Family Wellbeing at Sellers Dorsey, for introductions and today's content.
Thank you, Eric, and to MHPA for hosting this webinar today on a topic that I know personally motivates many of us, but I also hope will professionally inspire you. I'm Katie Olse with Sellers Dorsey, and I lead our child and family wellbeing work across the country. Sellers Dorsey is a national healthcare consulting firm that supports health plans, public agencies, providers, and other partners in helping to improve the health and well-being of people, communities, and systems. And we're a proud corporate member of MHPA. Today, we're going to talk about the child welfare system and the increasingly complex needs of children who have suffered abuse or neglect and who are now involved in the foster care system. The state's expectations are very high. The pressure is on for healthcare to better meet the needs of our children, and we need our health plans to help take on the comprehensive healthcare needs of children who have experienced unimaginable trauma. And this session will feature a panel of experts who have different roles and valuable perspectives on how managed care can help transform the child welfare system and those it serves. So let's meet our experts. I am going to ask each of our panelists to share their name and their role and the perspective that they're bringing to this conversation. And I'm going to start with Karen.
Thank you. I'm Karen McLeod, and I'm with Benchmarks. We're located in North Carolina. We represent provider agencies that do behavioral health care for children and adults, as well as developmental disabilities, substance use disorders. We represent agencies that do child welfare and juvenile justice. And so I come here wearing a provider hat.
Thanks, Karen. All right, Cheryl.
I am Cheryl Fisher. I'm the Vice President of Business Development for Foster Care and Child Welfare Programs at Centene. So I lead the work that we do in the foster care and child welfare space. Centene is a managed care corporation that's focused on Medicaid programs, essentially government-sponsored health care. We currently serve about 240,000 children with child welfare system involvement in 21 states across the country. So I'm coming today bringing that managed care perspective.
Great, thanks. And Scott.
Yes, my name is Scott Lundy. I'm the CEO of Arrow Child and Family Ministries. Arrow, we are a large provider of child welfare services in the foster care space and adoption. We have a robust behavioral health system as well, and a provider of those services. And we're also a lead agency for community-based care here in Texas. And so we get to really oversee the system for a catchment area. And then I'm also a proud foster parent, former foster parent and adoptive parent as well.
Most importantly, right?
Right.
Yeah,
for
your
sure.
dad. Great. Well, we've just got a couple of slides just to kind of level set folks' knowledge about the child welfare system. And so why this session matters, I mean, I think it's a no-brainer. We care about the healthcare needs of our children. So that you know, if you don't already, almost all children that are involved in the foster care system are eligible for Medicaid. And many children that are outside the foster care system are also, whether they're adopted or age out of the foster care system. We also know that kids and families involved in foster care have a higher need for health care and higher rates of long-term health-related issues compared to the general population. And we also know that we cannot heal trauma or prevent long-term health-related consequences without really effectively meeting the physical and mental health needs of children and their families. And we also know that child welfare professionals need managed care and the Medicaid system's help. The foster care system is perpetually strained and in crisis, and often lacks a deep understanding of Medicaid and how they can effectively use Medicaid as a partner. And to prove that point, next slide, you are all no doubt familiar with headlines around the country in every state that represent the imperfection of the child welfare system. And this is just a few headlines that we pulled together. I could have pulled many, many more from every single state in this country, but the child welfare system, the foster care system is struggling. It is fragile, and it is a safety net of all safety nets. So we know that we need to do what we can to help support it and to help save kids and protect families. Next slide. So just to kind of give you a little bit more of a backdrop, there are between 350,000 to 400,000 children or youth in the foster care system at any given time. That ebbs and flows by state, and it's somewhat cyclical as well, depending on the time of year. $30 billion, give or take, is spent annually on child welfare services, and that does not include the healthcare piece or the Medicaid piece. Historically, states have served the healthcare needs of children in foster care through fee-for-service, but many are moving or transitioning to managed care. There's about 26 states currently serving children in foster care through managed care, and 10 of those plus sign, because that's growing, are serving children through managed care through a specialty plan. And just to add more complexity to this already complex system, the Medicaid and child welfare agencies are often not under the same roof. Sometimes they are, but sometimes they are not. And then you've got state systems and county-based systems. So there's a lot of public players and a lot of private players involved in the system that all need to coordinate and work together for the good of the child and the family. So with that, let's get to the fun stuff, the questions. All right. I'm going to start with you, Karen, because we had a slide that showed some headlines. And we know that recently in North Carolina, there was a local news documentary about a very tragic case within the North Carolina foster care system. And you were actually featured. I just want to hear from you, kind of share your thoughts about these headlines and how tragic cases such as the one that you know too well can be used to bring system change, particularly as it relates to the healthcare piece.
Yeah, it truly was a tragic case. It was about an adoptive mother who murdered 2 of her adopted children through starvation and torture, and then forced one of the other adopted children to assist her in dismembering and burning the bodies. I mean, you just can't get much worse than that. And, you know, unfortunately, it oftentimes takes a truly tragic event to serve as a catalyst for change. And this case really is no different for that. It's captured the attention of legislators and citizens who are all clamoring for justice and want to see the child welfare system strengthen. We have taken this as an opportunity to draw attention to some key issues. One is that the child welfare system in North Carolina, like most states, is grossly underfunded. Another is an opportunity to move forward a large child welfare omnibus bill we've been trying to move for a couple of years. We're also drawing attention to the significant lack of available behavioral health care for our youth who enter into the foster care system. And it's also been a chance for us to highlight the disconnect in our state, and this is not uncommon from anywhere else in the nation, between our child welfare systems and the managed care companies, who continue to struggle to partner and communicate effectively, which ultimately impacts access to much needed behavioral health care services for children who are in the foster care system. And one of the things I'd note is that if you are trying to effectively seize attention on child welfare, it is so much more impactful if it's done in partnership between the state, providers, and the managed care companies. Collective messaging during this time of crisis really does serve to create an incredibly powerful voice to offer solutions to some really difficult problems. But to accomplish this, it's really helpful to have existing relationships and ongoing dialogue between the partners ahead of time. Trying to do this at the time of crisis is too late. So to that end, one of the things I would also note is I strongly encourage all states, all managed care companies, provider agencies, you need to be seeking out ongoing regular meetings between providers, managed care companies, and state leadership. This is crucial, not only for a strong working relationship, just to strengthen your existing system, but also provides a collective voice during a time of crisis that really gives you an opportunity to be able to access funding and intervention in ways you haven't before. And the other thing I would note is one of the things we've done is partnered with managed care companies. And I say we, our association representing providers, have partnered with managed care companies on legislation. And that is really, really powerful as well. And that's something else I would encourage other states to consider.
That's great. And there's a lot of health plans on the call today who might be thinking or scratching their head about, how do I even get to know my child welfare partners? That's a totally different system. Cheryl, you and I got to know each other in Texas. We were very intentional about making sure that the child welfare system got to know our health plan provider for healthcare for kids in foster care. So certainly, from your perspective, you have to be thinking, when you see a tragedy or a headline like that, how can the health plan help? Can you walk us through a little bit about what happens behind the curtain of a health plan when you see something like that?
Yeah, it's a really good question, and it's exactly right. We do start thinking, how can we help in this situation? What can we do? And a lot of times it's really digging in and working really closely with both your Medicaid partners, your child welfare partners, and even the other providers that are in your network to think through, how can we come together and could put together something in a collaborative way that's going to meet the needs of the children and families, and overall really raise the bar in terms of the services that are being delivered at the system level itself, because that's really the key there. And sometimes I think we didn't really realize it when we started doing this work initially, but as the managed care organization, you can actually be a convener of that cross collaboration, because not everyone already has a relationship with those entities. But as the managed care partner, you sort of do, because you have the contract with the Medicaid agency to manage care. You've got the contracts that you have with your providers that are in network delivering services. And then the child welfare agency serves as the parent for the child. So that's a critical partner as well. And so what we found is that we had the ability to utilize and leverage those relationships to bring people together, to have these conversations and really work together to try to solve the problem at hand. And that's something that's continued ongoing, not just where we started, but also in the states that we're working in today, to make sure that we continue that partnership approach, which to me, that's the biggest component related to assisting in solving some of these issues and figuring out what's the role that each party can play to get the outcome that we all desire.
And certainly I would imagine, and well, I know that you all are also looking at your data and working with your partners, because the goal is to prevent bad things from happening, to help kids, right? And so I'm sure that you're constantly looking to make sure you're ahead of things before something bad might happen, or an outcome that we don't want to see happens, right?
Oh, absolutely. I think that that's a key role that we can play as the managed care partner in looking at those healthcare services that are being delivered and identifying, first of all, ensuring everyone gets the screenings that they need, the assessments that they need, and that we're having the conversations on an ongoing basis with whoever's caring for the child, so that we're able to intervene and ensure that services are delivered before anything tragic like this happens, or even just making sure that behaviors don't escalate just in general, to be able to keep those families together.
I'm already going off script, Scott, so I'm going to throw a question at you that I did not tell you in advance. But as a provider, and so the case that Karen mentioned was where the adoptive parents needed help that they didn't get, and you run a provider organization where you are continuously supporting foster parents, adoptive parents, or relatives who are caring for kids. What does that look like for you in terms of making sure that your caregivers are supported?
Yeah, good question. I think the first thing I would say is we realize that we serve in a very tough space, and we realize that there are times that there are very dark things that are happening, and very messy things that are happening. And we try to trust the process, and the process really starts at the beginning, which is recruitment, screening, training, making sure that we're getting the right foster parent, and then going all the way through that adoptive process as well, of really analyzing that, whether or not it's a good fit. The other thing that we've really looked into is outside stressors, and really evaluating our foster parents and our adoptive parents with regards to what are the pressures that are coming in on them? Because I think, you hear the straw that broke the camel's back. There's always these stressors that are just piling on people. They try to stay in control that they have it. and oftentimes don't reach out for help. So really evaluating that is something that I think is critical.
Thank you. Cheryl, back to you. I mean, you heard Karen mention the need for funding and the advocacy work that she and her counterparts around the country are doing. But as we think about, the child welfare system is already a fragile system, and we want to strengthen it in order to help the kids and families that are involved with the system. I have to ask, there's a lot of uncertainty around Medicaid funding right now. What are your thoughts and comments about that?
Sure. Yeah, I know that it's definitely something that's getting a lot of attention right now. I'll say first and foremost, what everyone's telling me is it's still really early. Don't freak out yet. Let's see what's happening here. This is all playing out right now. I think what we've learned is that there's just education that's needed within the legislature for people to understand really the impact that cuts to Medicaid could have. I don't know that everyone really realized what a large percentage of Americans rely on Medicaid for their healthcare coverage. And so, we're obviously ready to partner with our states with whatever, decisions get made and however they might change their Medicaid programs. But I'll tell you where I'm most concerned is really thinking about those individuals who have been able to access Medicaid through Medicaid expansion, or maybe they're receiving their healthcare through the Affordable Care Act. And that's really impacting those caregivers, whether it's biological parents or kinship caregivers or our foster parents as well. So I am thinking about that and how just understanding that issues associated with poverty often drive child welfare system involvement. And so that's another reason why we're really keeping an eye on not just what's happening that might impact those children, but also thinking about those individuals that are caring for the children and what being really mindful of that and making sure that we're doing our part to educate individuals that are making the decisions about what the downstream impacts might be related to decisions that get made with cutting something like Medicaid.
Yeah, thank you. And I'll just put a plug in for Sellers Dorsey and our incredible team that has a finger on the pulse of everything that's happening at the federal level, but also very much integrated into the state, keeping up with all the state conversations as well. So sign up for our digest if you're not already. All right, Scott, back to you. I was hoping you could paint a picture for folks on this webinar of when we talk about foster kids, what is it? Paint a picture of who these kids are and the kind of needs they have, healthcare needs in particular.
Yeah. I think that my wife and I decided to foster 20 years ago. No, it's longer than that. It's 25 years ago.
Don't out your kid's age right now. Yeah.
Yeah. It's been a long time. And it was really different back then, so what we're seeing right now is we're seeing a significant drop in overall removals. Here in Texas, it's about 40%. I think nationally, I'm not sure what the percentages are, but I know that states are seeing that. And on the one side, that's a good thing because we got less kids in care. On the other side, what we're seeing is the kids that are being removed have gone through longer periods of trauma and abuse when they come into the system. And so we're having we're seeing it skew that we're having older youth that are entering the system. We're having youth that have complex trauma that has been caused by the abuse that they've gone through, but then also the removal. And then we have compound that trauma because most youth don't stay in just one placement for their whole time in care. And so there's movement there. We're seeing a lot more medical issues. There's a lot of medical neglect that's going on. We're seeing a lot bigger need for some serious mental health services and interventions across the board due to the trauma and just youth trying to deal with everything that's happening in their life that they don't have any control over.
Yeah.
And so it's a real challenge across the board. I think that's why you see a lot of child welfare systems are struggling, is everybody's got to be on their A game for this. And the kids that come into care deserve everybody's A game. So I think that's a lot of what's going on now.
Yeah, I have a special place in my heart for teenagers right now because I have two of them,
Yeah.
and they, you see a lot of the headlines around, capacity challenges and kids sleeping in hotels or offices or wherever, and a lot of them are teenagers with, very, big behaviors, and I say this a lot, like those are not bad kids, but bad things have happened to those kids, and they just really need the really intensive therapeutic support and care, regardless of the setting they're in. And so I just want to thank you and your folks that I know say yes to those kids all day, every day.
Well, and can I mention one other thing?
Yeah.
I was at a meeting before this, and I saw some data on a specific area here in Texas, and the older kids were staying in the system longer. But the other thing was at 2 years, what we saw was the amount of placements, the line just went straight up. So we were running at about 2 placements per period of time that they are in care. But once you got past that 2 years, it started going up to 7, 9, 10. And the older youth were predominantly the ones that were staying in care longer. And so it's kind of that double whammy with regards to more placements, more trauma, and older youth as well.
So we're using some child welfare lingo here, but placement is you're removed from mom and dad's house for whatever reason. And let me just say, states have to do everything they can to prevent a removal. So when a removal occurs, it is because there's substantiated abuse or neglect. And so then they're placed maybe with a foster home, maybe with relative first, maybe the needs are so high they might be self-harming, and so they're maybe placed in a more like a residential setting. And when you say placement changes, that means they are moved from that setting and placed in another and placed in another and placed in another.
Yep.
Right.
Sorry about that.
No, it's okay. And then the healthcare piece has to follow along, right, Cheryl? Then they have to have all of their healthcare needs met as they move placement to placement to placement. Yeah. Well, I don't want this to all be negative. So let's pivot to what I think is really exciting and more uplifting, which is the changes and the innovation on the horizon for how healthcare and managed care in particular can help serve this really, really important population. Karen, I just want to give you, and then we'll hear from Cheryl, kind of why do you think managed care is part of the solution to improving the child and family well-being system? And just highlight any innovations or any cool things you're seeing.
Yeah, they're absolutely critical in this and being successful. And one of the things I don't think a lot of people really think about is that the majority of youth who come into foster care pretty predominantly across the nation are under the age of 5. And this means that one of the most effective ways that we can identify, intervene, and reduce the number of children who are coming into care is actually through maternal and pediatric healthcare systems. That's actually our base, that if we were able to mobilize and use them in a really effective way in partnership with child welfare, there has to be a partnership built into that, then we could absolutely change the trajectory of the number of youth coming into care, but also keeping families intact, which is another big aim for all of us. So I really do think that if we again, in partnership with DSS, if we put an emphasis on the identification and reporting of children, not just abuse, because that's where they get them, right? But at risk, and that you have to define at risk, and people have to understand what that means. And some of that just means a mom who's coming in, who's struggling with a place to live, might be in a relationship that looks somewhat abusive. So it's identifying that at risk so that you can get in there early, so that you can reduce those children who enter care, but and keep families together. But for the children who do come into care, those that are even with us, then managed care is just as important. And that is because I think, Katie, you mentioned in the opening, and I know that Scott mentioned this too, the children who are coming into care oftentimes have a lot of unmet medical needs that end up leading to chronic healthcare issues. And so what we've seen consistently is the youth who are coming into care have pretty significant healthcare needs. And also, if they're coming into foster care, they've either experienced abuse or neglect to the point that's led them to come into care, and we remove them from their home, which is another trauma, right? A necessary one, but another trauma. And all of that means that we've got potentially a number of behavioral health issues that have to be identified. And so, to have in place that every child who's coming into care needs to be screened to determine if they need a comprehensive trauma-informed clinical assessment is imperative. And that ensures that a child has the right placement the first time and receives the behavioral intervention that is needed to keep that child's placement stable. And that's critical. The other thing you just mentioned, Katie, was, and this is what Scott was talking about, is the continuous moves, the disruption in the placement with a family, and they have to move to another family and to another family. Well, that also aligns with accessing behavioral health care. In a lot of states, children who come into foster care have to fail up to the right level of care. Mm-hmm. So they may start out in foster care, but then they move to therapeutic foster care, and then they move to some type of low residential behavioral, and then they move to a psychiatric residential treatment facility, and then they're an inpatient, where if we had really done the work right and intervened early and assessed, then we could have gotten that right placement with the right amount of service with the supports in place. So it was one placement is the only placement with a total goal to get to permanency. And in the child welfare world, for those of you on the Medicaid managed care side, your lingo and your way of seeing things doesn't tend to be around permanency, but permanency is a key component of child welfare. And what we mean by that is getting that child to their forever placement. It could be family, it could be a relative, it could be what we call a fictive kin, someone who cares about them deeply. But all of that matters, and it matters for our medical side as well, because we know that a child who gets to permanency quickly has so much better outcomes and has a lot less behavioral health needs. So it behooves us that we're working together to achieve this. And some of that effort is around aligning the goals between managed care and the implementation of managed care through your whatever managed care type that you have, as well as aligning with the child welfare together, a plan together. And we don't see that in many states at all. Now, North Carolina, we're super, super excited because we're about to begin a carve out for a whole healthcare, physical and behavioral healthcare system for youth who are in foster care. But it doesn't just include the children in foster care. It includes if they have eligible caretakers, say mom is Medicaid eligible, and their siblings can all come into this carve out together. So you're doing whole family health care. And we know how important that is, because when a child comes into care, oftentimes another sibling is going to end up coming into care at the same time or later. And you'll see family come in over periods of time. This is to address the whole family at once and try to get the services in place the way they need to keep that family together intact, or to get the child home as quickly as possible. So all of that is super exciting, but even more exciting for me is not only are they doing whole health care, but they're also going to be looking at risk of coming into care. So trying to get out in front of it. And they're going to be, and just FYI, it's Healthy Blue. They're going to be starting this in December of 2025. In addition to this, they're going to be looking at social determinants of health, which is one of the #1 reasons that our families come into care. They're going to be looking to address social determinants of health for those at risk and for youth who have come into care, to help strengthen that family so that we can get kids back home wherever possible as quickly as possible, and we can keep families together wherever we can. So we're really excited about that. I could go on about a lot of other innovative, but I've talked too much. But if you want to know about really cool practices that we are seeing in North Carolina, I'd be happy to talk about that later.
Well, that's exciting. We're all eagerly awaiting and rooting for Healthy Blue. I think that's going to be an incredible program, and congratulations to you, Karen. I know you fought hard for that, and so we will all be excited to see the good outcomes that we know are going to come from that. Cheryl, I want to hear from you. Kind of what's innovative and exciting and giving you kind of hope.
Yeah, no, I think I want to just echo some of the things that Karen talked about, because one of the things I know she was mentioning was about permanency and how that is, you know, such a important component in the child welfare system, and how that language doesn't really come into the Medicaid managed care space. And so if you are in the Medicaid system or with a managed care plan, you might be thinking, what role do I have to play in permanency for a child? And the fact is a pretty big one, because I think a lot of times it's, how do we're not identifying placement, and we're not identifying whether a child becomes adopted or goes back home. But a lot of times it's the services and supports that we can make sure we wrap around that child while they are in foster care that can actually speed up their process to permanency, whether that be return to biological family or adoption. And so thinking about those healthcare needs that I think everyone on this call right now has done such a great job of explaining, the trauma kids have experienced and the healthcare needs they have whenever they enter the foster care system. A lot of the work that we can do is to address those issues and really try to get the services and supports in place so that that child is able to achieve permanency in the end. So I just want to make sure that that's clear, that there's a real role for the managed care organization to play to really support the child welfare system as they seek permanency. I think that the other thing that I want to bring up too is, you know, the mention about kids moving from one placement to another when they're in foster care, and how that does contribute to the trauma that they've already experienced. And that's another really critical role for the managed care company to play, because when you are the MCO for the child, you're actually the one who has all of that healthcare history and all of that information, so that as kids do go from one home to another and potentially need to change providers, it's not up to just the caseworker to try to make sure that that information is shared. You have the ability to share that information with a new caregiver and to share that information with a new provider to make sure that we're not seeing duplicated efforts or restarting something that maybe already was tried and failed with a child, to make sure that things keep moving forward for a child as they're working through the foster care system and on their path in their journey in terms of their healthcare needs as well. And so with that, I think that some of the things that we really see too is the effort that the MCO can play in terms of relieving some of the burden within the child welfare system. We've spoken a lot today about just the strain on the system itself. And caseworkers do really bear the burden of being responsible for everything for a child. And they're focused on safety, permanency, well-being. And now the child needs a specialist, and now they need these behavioral health interventions. And so that's really where the managed care company can step in and try to relieve some of that burden. So while the caseworker is focused on the things that they do best, we can actually focus on those things that we do best, and we can help them find an appointment, and we can help arrange for that transportation for them to get to the appointment and things of that nature. So that's really important. In terms of what's on the horizon and the things that I'm really excited about, you know, Karen touched on the focus on SDOH needs. I think that we're seeing a lot more of an ability to focus on those needs to try to make sure that we're addressing those issues within that the kids have, but also with the families that are caring for them, and how we've been able to kind of change that with the in lieu of service option. So there's a real opportunity within Medicaid to think about how we can deliver services in lieu of those services that are more costly, that like inpatient and residential treatment that none of us like to see kids stuck in. And if we can figure out what are those intensive in-home services that can be provided instead of that, or potentially even in some states, they're looking at how do they fund some of those SDOH needs instead of some of these high dollar medical needs that we think will lead to better outcomes in the end. Obviously, we're still working through some of that and waiting to see some outcomes there, but I am really excited about that opportunity and the ability to leverage that option to be able to cover some things that we just historically haven't been able to cover within the parameters that we've had up to now.
I love that. I love that. Thank you. And Scott, thinking about, you know, addressing the social determinants of health and some of these sort of just like community or societal issues, you know, the health plans really do need a community partner to do that. And you earlier, you mentioned community-based care. And for folks on this call, traditionally, you know, there's been managed care or Medicaid over here, and over here has been a sort of a scattering of child welfare providers that all contract with the state agency. And in some states, and Texas is one of them, and Scott, you're a pioneer of this, we are organizing child welfare to look more like managed care, where there is a community lead agency who's responsible for all the services and the overall case plan and getting to permanency for the child and the family. And you are one of those agencies, one of those entities in Texas. So I was wondering if you could talk a little bit about how you've been able to, through this new model of community-based care, no longer are child welfare providers necessarily adjacent or sidelined. You're actually finding a way to partner with an MCO.
Yeah. First of all, I think before community-based care, they were very siloed. They were different buckets of money. And so, the child welfare agency, the state child welfare agency would say, hey, you got to get all of these services over here with this group. And so there wasn't a lot of communication that was going on. And when you really look at, so one of the things that we did once we became the lead agency for that area really was meeting with the MCO and looking at what are their pain points and then what are our pain points. So some of our pain points may have been access to certain services in very, very rural areas to where there just weren't a lot of specialists or providers. And some of their pain points also were definitely with the medically complex children and some of the movement between placements. And so as we began to look at it, we decided, hey, we can help with some of the medically complex. And so we really developed I guess it's in lieu of, but it's really a service that didn't exist, which is called medical equipment transport services. And it was when you have a very medically fragile child that is having to move, whether or not they're having to go to the hospital or having to go to a different foster parent, is that we would send medical professionals to go to break down the equipment, to then transport the equipment with a medical van instead of in the trunk of the caseworker's car, and then take it to the new place where the child is going, set it up, train the foster parents on it, so that it prevented loss of equipment, it prevented damaging of equipment, and it made sure that the foster parent felt competent to really know how to work that equipment, the new foster parent. And so I think we've seen some really cool stuff come out of that. And that was just sitting around at the table talking about what was the MCO's pain points and what our pain points were, and really trying to figure those out. Now I can say since then, I got them on speed dial, they got me on speed dial. So it really is, as things are coming up or different, challenges that are popping up, whether or not they're with an individual need or something like that, or more of a trend that we're seeing, we can work together to address that. And they have a lot of flexibility, and we do too. And I want to hammer that home, because that really is the most critical thing, is having flexibility to say, what does this child need? And let's figure out how to get it. Or what does this family need? And let's figure out how to make it happen. And when we have that flexibility, some really good things can happen.
I love that example, because it's so easy to understand how frustrating that would be for a foster parent or a caseworker. And that's such a great example of something kind of simple, but a big problem. Thank you for that. We have a little more time. I want to make sure that we're getting to some of the questions. So Scott, while you're on deck, and then we'll ask the others as well, we've talked about the goals of the entire system really being to prevent child abuse and neglect, or if there's high risk, how do we keep families together and not remove kids, which we call family preservation? Or on the back end, if a child's in foster care, getting them back home to their family of origin, so we can preserve that family after a foster care involvement. So Scott, can you just sort of share any remarks or thoughts you have about that?
About more services that we need on the front end.
Yeah, or opportunities that you might see. I mean, we're thinking healthcare here, but certainly there's interest from the healthcare side, just like there is on child welfare, and working with these families before, the deepest end of the child welfare system is needed.
Right. Well, I can tell you, and just a real life example is with one of my children, and later on, and after adoption, and as she got older, she wanted to meet and visit with her bio parents, and we took a trip, and we did that, and it was fantastic. It was healing for them. It was healing for my daughter. It was healing for us. It was just, it was incredible. But it really laid on me that what did we do to help support that family when we knew they were in trouble? And if we could have put some things there in the front end, could we have prevented that removal? And I think there are a lot of evidence-based models out there that really do a good job at this. And, it's really convincing states to kind of lean into that and be able to do that. When a child is removed, and I'm going to overgeneralize this, but I think with regards to the bio families, a lot of times we give them a list of things that they need to do and accomplish. And then we give them a list of providers that they need to contact in order to accomplish these things. But we don't assign them mentors. We don't assign them and really help them with that plan so that they can be successful. And it's kind of a pass fail. If they're able to do all these things by a certain time frame, then they have executed their plan and they get their children back. But if we were sit there and really work with them and be more as partners, I think with them, I think we'd have a much higher success rate all the way around. And many of those would definitely involve the MCO as we look at different issues that families are dealing with. And we hear it's cliche, it takes a village, but it really there are so many touch points that these families have: schools, healthcare, behavioral health, and other providers, and really coordinating to where everybody is kind of trying to work together towards what's best for this family has been a challenge, and it's something that we need to get better at.
Cheryl, many of these families we're talking about are on Medicaid and being served by health plans, right?
Yeah. No, I think that's right. I mean, a large percentage of kids who come into foster care had Medicaid or some other type of government-sponsored healthcare assistance prior to coming into the system. And so I agree with Scott to say that we definitely need to get better. But even thinking about the strides that the child welfare system has taken in recent years, we see the decrease in the number of kids coming into care. And a lot of that is because we are getting a little bit better at that, right? In terms of really recognizing that if it is a financial issue, if it is, something where we can actually intervene to keep that child in the family, that's going to be better for that family overall. But again, I think we can get better at that. I think that I've seen some states making some changes to how they're, when they think about the specialty plans for the kids in foster care, and really expanding on that a little bit to essentially allowing the kids to stay in the specialty plan for a period of time post reunification, or allowing for services within the specialty plan when the child is identified for prevention services. That's something that we are really, we really are supportive of those kinds of concepts, just because that ability to intervene early, or the ability to continue those services after a child returns home, we think is really important for the success. And to see that continuity within the family is another factor I think that's really important. And then the other thing I'll say is kind of, let's kind of get even in front of any kind of child welfare system involvement. These families are not on anybody's radar yet, but they still are receiving Medicaid. So I think we're seeing all states have such a focus on maternal child health. I think, Karen, you were the one who mentioned that how young the kids are that come into care in large percentages. And so if we can identify those moms that are at risk, when they're pregnant, especially since we know substance use drives some of this as well, and how do we intervene with those families to try to keep those families together at that point in time, I think is really critical. And that is when we all know about them, right? There's a woman, she's pregnant, we're aware of that, and we can provide some interventions there. And so I think I can speak for most managed care plans. I suspect we all have some sort of programs to essentially wrap around those moms. But I think, again, we're getting better at that all the time. And there's still, I think, efforts to be made as far as that goes.
Awesome. To the person that asked the question around, are there opportunities for pilots and innovation and different ways of funding and grants and performance-based contracts? Yes is the answer. So call me. We'll talk about that. That would be an exciting, entirely other webinar, though, because I think there's so much there to talk about, and every state is so different. And Karen, I'm going to ask you this one. There's interest in legislation or advocacy around getting more of these carve-outs or specialty plans, or at least more kids that touch the child welfare system across the whole stream in managed care. And you've been so successful in North Carolina. So advice?
So I'm so glad you asked this, and I am so excited for the other states that want to see this happen. This is really hard to get right. And you might be asking, well, why is it so hard if somebody else is doing it? Well, it's because it requires at a leadership level, a lens of child welfare and a lens of Medicaid working together in tandem to design what it should look like. And that is really, I didn't realize how that is really, really, really hard. And I would note that, as an association, we work across all the platforms of Medicaid and managed care companies and mental health and child welfare. And one of the things we've really come to understand is that these groups don't speak the same language. So one of the things that we've seen, I'll just give an example. If somebody talks about in-home services for child welfare, it means something very different than mental health. And so that's just one example, but as an association working across all of them, we spend a lot of time interpreting between and saying, nope, that's not what you think it means. It means this, and let's all get the same definition. So a lot of this is really about trying to create that synergy of language and also vision, mission, because again, the example that I brought up before around trying to drive to permanency, when we first started having that conversation on our plan, because we were very engaged in the process of developing it, that didn't make any sense to mental health. And we had to keep talking about it, Medicaid, over and over for them to say, oh, yes, we understand that, and we want to put that in our lens. And so it requires a tremendous amount of collaborative I'd call it cross-pollination, but that getting those divisions and departments to talk in a way that they could understand each other. Utilizing, for instance, your state association or someone who works across those can be absolutely crucial to making this work effectively. The other piece to it is when child welfare comes at the table, and a lot of states, they are very separate. Child welfare is separate from mental health and from Medicaid. They don't even know what services there are to have. Like, they're just coming in blind. So they don't even know how to get into that conversation. And having the ability to be able to say, you know what, for our folks from Child Protective Services, I would like you to really talk about this, having someone who can intervene and provide that support. And that I'll do a shout out to Katie. That's something Sellers Dorsey that with Katie could come into your state and actually do that. I'm not trying to do a prop for you, Kate, but you are fabulous. And I think the world of you. But that's the kind, finding the right person, whether it's in your state through your state association, and not everybody has one, or, finding someone like a fabulous Katie to come in to really be able to create that connection. But the other thing is it's very easy to default to what you already have, but stick it in a carve out. And there's no point of doing that. You're just repeating what you already done. So if you are moving to a carve out, you need to be looking at, how do we make this different? How do we set the bar to a very different place? How do we drive this to permanency and keeping families intact and doing whole family care? We talk a lot about whole person care for children, but littles come with biggies, and they're 100% dependent on healthy biggies to thrive. And so we have to think holistically about a family in this environment. And that sometimes is a little tricky on the Medicaid side too, because Medicaid is set up where you identify a service, you then determine if the person's eligible for the service, and then you get the service. So pulling that back and saying, we've got to think about this from a family system is really hard. But I have to say, once you get the right people at the table, and you have a state that's truly invested in not just moving this to a place where we have better outcomes, but I will add the other piece. It's a massive cost savings if you do this right. And it's cost on money and it's cost on lives. People's lives are better. So all that is good stuff. But once you get the right people together, some pretty cool magic can happen. But I want to go back to something else that Scott said earlier about flexibility. When you're putting these new systems together, they're hard. And there is not a magic, like I keep saying, I'm going to pet my magic unicorn and we can all have some kumbaya. But it is hard, and it requires that when we hit those spots of stuff we didn't anticipate or things that are challenging, that we are given, and I say we, I mean state, managed care company, providers, like everybody in the system, we need to give each other grace to say, okay, this is not something we anticipated. Let's work together. Let's not point fingers and yell at the other. Let's work together to figure this out. And to do that, and again, if you're thinking about doing this for your state, you have to build these healthy relationships between all the partners. And with that, I'm going to just stop my rah-rah.
I mean, I think you could all see how Karen was so effective in getting this through in North Carolina. You're a rock star, Karen, so thank you. All right, we are almost out of time. Our theme today is how Medicaid managed care can help improve the child welfare system. So we're going to do rapid fire. I want you all to just think about, Cheryl, your experience with Centene, and you have the breadth and depth of this work across the country. Scott, your experience as a provider on the ground, working with children, and of course, a foster and adoptive dad. And Karen, your perspective as a driver of the system and who is at the public policy and funding table. What is something you want folks to take away from today's conversation? Karen, you want to go first?
Two big things I would recommend. One is earlier intervention at risk. I would love you to take that away, because if we can start there, we're starting where we're throwing the babies in the water over the waterfall, one of those. And the second piece is substance use disorder services. One of the major reasons kids come into care, one of the least available services in most states. If we invested heavily and did really good evidence-based substance use disorder work, we would pretty much eliminate a large portion of the work we do in child welfare. And wouldn't that be amazing?
Cheryl, thank you.
I'm going to say partnership. I think you've heard that throughout the day, and I would just hope that you take that away, that it really is important to think about how do we work together, because no one can do all this work alone. It takes multiple systems, including the Medicaid managed care partner, to come together and work together. And so the big thing I say to take away is just get ready to really get in the trenches and partner together.
Thank you. And Scott?
I think the other thing I would throw into the mix is there's a lot of faith-based and community partners out there that are doing really good work in supporting families that oftentimes don't have the information that a family's in trouble. They don't have or maybe they do, and they don't know who to share that with. So I think really connecting them in kind of this loop between managed care, child welfare, and early intervention is really looking at those community partners that are out there that are, helping with clothes closets and food pantries and different things that are helping to support families.
Awesome. Well, that's why I had y'all go first, because I could just say ditto to all of that. And I'm just going to add appreciation for everybody that tuned in today. This is really hard and kind of gut-wrenching. And so I'm so grateful for everybody that tuned in and for MHPA for hosting us today. This is a pivotal moment where healthcare and child welfare can come together to really improve both systems and, more importantly, the lives of children and families. So thank you so much to MHPA for hosting us. And Eric, I'll turn it back to you.
Absolutely. Thank you so much. I just want to echo Katie's thanks to everybody for joining us this afternoon. I also want to thank Katie, Cheryl, Karen, and Scott for their time. Obviously, given the incredibly dynamic Medicaid landscape currently and the link between Medicaid and the child welfare system, I thought this conversation was incredibly insightful and interesting. As a reminder to all of our attendees, we have recorded today's session. So if you want to revisit it at any point, you can find that on MHPA's YouTube channel. You can also obviously reach out to Sellers Dorsey. Katie has been kind enough to share her information there. You can also reach out to me at MHPA. I'd be happy to connect you as well. With that, I want to thank everybody for their time, and I hope everybody has a great afternoon.